next we have the sponsor panel coming up. So I would like to invite Eliana, Deb, and Tracy to come up to the front. There's the little blue table on the front side of the room. And Dr. Maria Santana will be asking questions to the panelists. We're also going to be inviting Joanne Ganton and Dr. Rohan Souza to join us virtually. So we will start with the panel session.
Thank you so much, Dr. Castillo, Marsha, and Wasilak. It is a pleasure for me. I know you have very busy lives, but this is a very dear program for all of us. So thank you. The idea to bring the sponsors is that we had so much information and learning sessions from the PaCERs that put the spotlight on the PaCER graduates. They've done wonderful work. We've seen it. And now I think it's time to ask the sponsors. And I think we have Dr. De Souza from McMaster University or the hospital there join us virtually. So welcome, Rohan, and thank you for being here with us.
Thank you so much for inviting me.
And we do also have Joanne Gatton. Hi, Joanne. Thank you.
Good morning. Thanks for having me.
Yeah, pleasure. Thank you. So, so just one overall question, just if you could tell us about the project that you sponsor and your overall experience working with the PaCER students. Shall we start with the people online? Joanne, would you like to start first? I know you are attending another conference.
Sure, yes. I'm in transit somewhere, but so I'll keep my camera on when required. Yes, it was my first experience sponsoring a PaCER group, and I think I know every parent that's biased. I feel like I just got lucky with the best group ever. We had the most very committed group of 7 people from very diverse backgrounds with a lot of diverse lived experiences of pregnancy. And the project was about conceptualizing pregnancy-related morbidity from the perspective of people with lived experience. And for those of you who are not aware, when we talk about what goes wrong in pregnancy and what needs to be fixed, it is normally clinicians and researchers that sit around a table saying, well, these are our priorities. And we tend to leave people that have actually lived the experience of pregnancy completely out of the conversation. And so this was an opportunity to have people that have had lived experiences of pregnancy ask themselves and each other a question of what is it that we consider pregnancy-related morbidity. And the results that came out of that project were really humbling, and they've been eye-opening for me. I just think that the commitment that the candidate showed was overwhelming. It just made me so convinced that we need to give opportunities to non-researchers and members of the general public through programs such as PaCER, and empower them to do research, because they do such a great job when they're given the opportunity. I'd just like to end by saying that I've been so impressed and inspired by it that I've now convinced some of my American colleagues to about the PaCER program, and we've applied for a PCORI grant. We put in a letter of intent, and PCORI liked it really very much. And so if we are lucky, fingers crossed, there will be a joint US-Canadian cohort of people with lived experience of congenital heart disease that have gone through pregnancies, doing some research in this area through PaCER. So really, it was a real pleasure. And I'm happy to answer any specific questions that you have, Maria.
Can you hear me now? Yeah. Rohan, thank you so much for describing your experience and being such a champion and ambassador of the PACER program. I am keeping the fingers crossed for that grant with the states. Yes. I think Joanne is online as well. So Joanne, would you like to tell us about your experience and a project that you have worked with the PACER?
Sure. I think I originally sponsored a PACER project way back, probably at the beginning, focused on work that was underway at the South Health campus at the time when PaCER was first starting out. But then more recently, in 2022, I was lucky to be able to be part of a PaCER team with 5 patient partners. And our project's focus was what supports matter most to people when they're returning to their homes in rural and remote communities after being hospitalized. We had a really incredible team who were really motivated, and they were passionate to learn the PaCER methodology, but they were also passionate about the research topic. And this was in support of the home to hospital to home transition work that's underway in the province. Overall, I think the PaCER program, I find it's really helping to build the knowledge and the skills and the confidence of our patient partners. And that was just so evident in our team and in the entire cohort that I saw just the skills and that confidence of our patient partners. And that helps in our work in AHS when we do partner with a variety of these folks after they've completed the PaCER program. And so just looking forward to where it might go in the future.
Yeah, if you can go next. Yeah, thank you so much, Joanne. Thanks.
Thank you, and thank you for the opportunity, Dr. Santana. So I am a clinician, one of those in the ivory tower. I've been a clinician for 20 years. I am a new researcher, and I had the opportunity to sponsor the WeCMB team that we just heard about. Part of the things that I've been doing for the last 20 years has been writing guidelines for my colleagues. So writing guidelines to tell my colleagues about things like, we should be talking to pregnant people about CMV. I can tell you that it took me 10 years to work through the ranks in the Society of Obstetrics and Gynecology to get a guideline published in 2021. It was the first one in North America to have specifically advised people who ask prenatal care to talk about CNV. We talk about the cat litter, right? But we don't talk about CNV. And the last case, congenital toxoplasmosis, which is what pregnant people get from the cat litter. We've had one case in 25 years in Canada. 1 in 200 babies are born with CNV. So after 20 years of have left me feeling that that I needed to find my patients where they were. And that's why actually PaCER came to me. And in my new life as a researcher, and again, I make my eyebrows like this because I am not a real researcher like Dr. Marshall or Dr. Santana, that they do the real stuff. In my research team, 2 of them are actually PaCER graduates, and they don't have PhDs, and they don't have, humongous CVs with multiple papers or hundreds of papers. They have lived experience, and as a clinician, trying to affect change through different avenues, to the ones I've used for the last 20 years. Those 2, Maria and Marcia over there, PaCER graduates, they keep me real. And listening to the WeCMB presentation this morning, I just can say that there is a lot to do. And there is an amazing amount of work that people like Dr. Santana and Wasilek and Marshall have done. So we are having this conversation here today.
Yeah, thank you.
And I'm
Yep.
supposed to go
Yeah.
after that?
And go. Yeah.
Oh my, yeah. Just so you know, everybody, yeah. Wow, okay, well, I'm Deborah Marshall. I am a researcher here at University of Calgary. I feel badly about saying that now. But here we are. PaCER's been amazing. So I have had the privilege and the pleasure of sponsoring from the very beginning, because actually Tracy and I don't like calling myself a grandmother, Tracy, but we've been in this from the very beginning before PaCER was PaCER. So I had the joyous pleasure of working with two of the very early PaCERs as well as others, but I can reflect on what I learned, and let me put it this way. PaCER to me is lifelong learning, and this researcher is continuously learning from our PaCERs, I can tell you, in every single project. And we flipped the way we think about research, the way I approach research, the way I engage. Virtually in every project we do, we have PaCERs, or not PaCERs. They don't have to be PaCERs, but patients are on our research teams, our grants, our projects, et cetera, et cetera. But I had the joy of working with two of the very first PaCERs, Jean Miller and Sylvia Tier, who you may or may not know. And I have to tell you, they worked with the SENs, sat on the bone joint SEN. They had the ear of the minister in sharing their messages about what they called life behind the locked gates. So this was an osteoarthritis project. That's how PaCER started. Was the first focus on osteoarthritis, which is an area we both worked with very closely. They described what it's like, and I hear the same themes. The need for continuity of care, for support, because the waiting lists are so long. What do I do while I'm waiting? Help me, was the message from Jean and Sylvia and their team. So that was the very beginning. And we've done a whole lot of things since with them. And it's evolved into multiple projects, a whole program of activity. Furthermore, they've been involved in reviewing grants, being on grants, mentoring others, being on CHR review panels, developing, the compensation guidelines. So Jean and I were involved in creating those with CHR, I don't know, 5 years ago, 6 years ago, I lose track of time. They were involved in it. Their voices were all part of that. So the influences, I think I can't even fully describe because of all the different aspects. So then fast forwarding today, very proudly, it's nice to see this amazing STIR team around youths and mental health. And we had the opportunity to sponsor that cohort through the Alberta Children's Hospital Foundation through a grant. And we're looking forward to engaging them. They've done amazing things. The dynamics, you saw the presentation, so I won't repeat that. But it was really challenging and interesting because now PaCER is morphed into working with areas like mental health. Well, that poses some additional challenges in how one does that and how one approaches that. And then I'll just say the other recent experience in sponsoring a cohort, I think we sponsored one in every year, is working with youth. We had our first youth cohort, and this is in juvenile arthritis. And yes, kids do get arthritis. And wow, they are unbelievable. One's founded her own charity and information. She does the podcasts on what it's like to live with JIA. And she's working intensely with our childhood arthritis research program nationally. And she's just amazing. And the energy is inspiring. Whenever I get depressed, I think about these people and say, yes, we're doing some good things. So that's my experience. I've learned so much and I'm so grateful and continue to learn from and be inspired really by our PaCERs. And remember, why are we doing this? Every day, because that's what matters. So over to you, Grandma.
Thank you, Deb.
I don't know what else to say. Oh, is this on? Yeah, I don't know what else to say. I think I'm a grandma wannabe. But I am a grandmother. And so, I'm going to talk about this from a health system and a decision maker perspective, because even though I kind of dabble in research, I really, I surround myself by expert researchers, expert clinicians, and expert citizens with lived experience, because the formula for transforming healthcare is to really get everyone's views on the table, focus on what's really critically important, and then tackle those challenges. And when I started in this journey, I was interested in really making sure that we were not creating a tokenistic approach to engagement of citizens, patients, those with lived experience, because we had a history of that in healthcare. You put a patient on a committee, you pat yourself on the back and you feel really good. Yeah, I've had the voice, but nothing happens from that voice. Or concurrently, you get them to do a digital story and then it goes off into the ether, but you didn't really do anything about the story. So PaCER was really for me about giving skills and strength to citizens to actually do something about their lived experience in a tangible way that would draw the attention of decision makers, draw the attention of academics to pay attention to patients, not just as subjects, but as subject matter experts, and for clinicians to say, wow, these people have real value in what's really important to them. We need to pay attention to it. And I still remember in the early days when we launched, we had PaCERs there at the launch. We felt it was really critically important. They were all in the course at the time, or had just recently graduated, I think, out of our PEP grant. But they were at the opening of the networks and had a voice at the table, which a very dear friend of mine who's no longer with us said, if you're never invited for dinner, you're always an afterthought. So, make sure that patients and citizens are on the invitation list to dinner. And when we were at one of our first core committee meetings, so you've got all these really important people around the table. So how do you level the power differential? How do you make sure that patients actually talk at these meetings and their voices are heard? But I remember Jean and Sylvia saying, you know what, you guys are all fussed about a waiting list, but I have OA. I'm 5 years from getting a joint replacement. You put me on a waiting list. You've helped make me depressed because I can't move. You haven't treated my pain. You've given me no idea about how to self-manage in this new journey of OA. And at my very lowest, mentally, physically, you want to operate on me. So what's important to us is, can you get upstream from the waiting list? And the whole room stopped. And there were rheumatologists and surgeons and decision makers. And a rheumatologist spoke up and said, oh my God, that isn't even on our radar. And so to me, that's the essence of PaCER, is putting the importance of your lived experience on the table as an equally meaningful opportunity to study, build a guideline around, transform. And that's why I've been a sponsor since 2011. And our networks are heavy sponsors of the projects that you all saw. I remember Amelia came to me and said, would Mincy, be in? I said, yeah, we're in. You'll have to help find the patients, but we're in, because I think this is a movement that I feel very passionate about. I hate to see it get lost, and it's why we've invested heavily. Our Indigenous health team invested heavily in getting the digital capability, the continuing ed program, and I am thrilled that you guys are going for the Corey funding, because we've tried for years. So to me, that's just another example of how progressive approximation to what Nancy Marlett would say, citizen science, is leading us to. So thank you for listening to me. Thank you for the opportunity, Maria, to be here amongst all of you. And congratulations to our recent grads on their great work. And my pain group, love you, saw the poster. Yay. Thank you so much.
Thank you so much. I had 3 questions for you, but I've been hearing the 3 questions summarized to certain degrees through the discussion. But if any of you have a comment about how patient will look like in 5 years, where are the core pieces that we need to preserve? What comes to your mind? The first thing. Maybe we start with Eliana. I don't. Rohan, are you here?
I am here. Yes. What I think it's not just a question of 5 years. Even now, I see patients as much more engaged and much more involved in their care. I see people being much stronger advocates for each other. And all of this is very positive. I have the privilege of working with a group of pediatricians and at McMaster University, and it's just inspiring how involved parents are right from the very beginning in the health of their children and in decision making. And the reliance of pediatricians and researchers here on patients to inform them about just everything is infectious. So much so that within the Department of Obstetrics and Gynecology, where I am, we now hesitate to submit any grant or any application without having patient partners meaningfully engaged, not just nominally included on the grant. We have them right from the planning process, asking them whether we are asking the right question. So we've got patients really actively involved, and so I see this as a revolution. It's a silent revolution, and I see how in the future there will be a lot of emphasis on responding or answering questions that have a direct consequence on outcomes that are important to patients and not outcomes that are important to clinicians or researchers. Thank you.
Thank you, Rohan. Yeah, and I think that PaCER plays an important role in that. Yeah, thank you. Joanne, would you like to add? Thanks.
Yeah, thank you. So I come from more of an inside Alberta Health Services perspective. I'm a patient family center care and engagement specialist, heavily embedded in a lot of our quality improvement work. And I've kind of always had this dream or this hope that we would have all of our quality improvements or most of our SCN projects would really start with PaCER research. So start by doing research about what matters to patients and what they're really experiencing, and then using that research to drive the priorities from a patient needs perspective right from the start. And I think that would really help to bring the patient voice and experiences much earlier in the project. You know, to Tracy's story a minute ago about having, you know, those patient advisors at the table and sharing that. I think if projects started with PaCER research, we would bring in more diverse voices and broader voices of more patient experiences that could really help set some of the priorities right from the very beginning. Versus I think some of the PaCER projects come along much later in the evolution of projects. So it's kind of always something I've been trying to strive towards and champion within our work, is to reach out and do more of that PaCER research and learn from more patient experiences. And let's use that to help set some of our priorities right from the very beginning of our projects.
Thank you very much, John. Yes. The importance of the PaCER students, graduates bringing the learnings to the table. Yeah, I mean, used to improve quality of healthcare. Dr. Castillo?
So if I would look back in 5 years at the PaCER program, I think it's crucial to keep the core of their work so far, and I see it as all of you being pollinators. Right? We have very big problems. We're recovering from a pandemic. We have another pandemic coming up likely soon. We can make vaccines in a matter of weeks. We can put them in shelves we cannot get them into people's arms. And each PaCER is a pollinator to bring the lived experience that decision makers, the industry, the scientists, the politicians need to listen. So I think that is core, that way, that directionality needs to be kept. If you ask me what I think PaCERs can evolve into, I think it's very important that PaCERs evolve into the open science space. A lot of the work that has been done with PaCERs, by PaCERs so far, has been to more or less still fit within the rigid terms of academia. Posters, presentations, grants, align the budget of grants, all of those are still the confines, the very square confines of academia, academic outputs as we see them. And yet, all of us know that it takes at least 20 years from knowledge, from knowing to doing. And I think in that gap is where, and I think open science, Dr. Santana, that is, it's a concept where we have to get to. So how can PaCERs get the science out of the ivory tower into where it's needed the most? And I don't ask me how to do it, but I'm pretty sure people in this room and beyond will be able to figure it out.
Well, there you go. That should be easy. I think for me, if I had to say it, and I'm sure you want us to be brief at this juncture, I think prioritizing, and I'll build on that, using the patient voice to really try to understand what are the priorities, what matters to patients, and therefore drive, if I could say, the agenda. And I think also be willing, and maybe this is part of your idea, to step outside of, the confines, I guess, of the way we think about things, because we're trained that way. So researchers are trained certain ways, clinicians are trained certain ways. We're all, finely trained to do something. But what I think PaCERs and people with lived experiences more broadly help us do is essentially reimagine healthcare. Well, I don't think we have a healthcare system. Sorry, at the risk of being difficult. But what is this called? The patient-centered, like, let's reimagine what patient-centered health, and care always bothers me a bit too, but health and wellness actually looks like, instead of operating within our existing structures. And I think that's what working with PaCERs at least helps chip away at, in my mind, because they challenge the way you think. Go, well, why are you doing it that way? We always do it that way. And I think we all need that every day. And that's the challenge. So reimagining and rethinking health and wellness is what I think it can really do.
Thank you, Deb.
Yeah, just going to be super brief. One nugget that was really apparent to me when I first watched the set, collect, reflect methodology was patients are telling other patients things that we as clinicians or researchers never got. We never got that story, so 5 years from now, I hope there's not a team that doesn't engage, have a PaCER as part of that. What are we going to study and why? And from a health system perspective, I'd love to see PaCERs on every quality structure that we have, so that we're being very true to this idea that we're trying to improve the health and wellness of Albertans for Albertans. So it's that evolution that I hope we can get to. Thanks.
For the discussion, and we're going to We don't have time, but we're going to have maybe a couple of questions from the audience for you. Now it's working. Okay, this mic is a little bit temperamental. Maybe just one question and then you can take other questions during lunch. Because otherwise the food is going to be very full.
Okay, I'll try and keep this brief as I can, but what I'm thinking about is next steps and how PaCER can be used to inform not just research, but specifically clinicians and specifically the cultural sea change that is required because of, it seems like a theme that wasn't just in my group's long COVID research, but all of the groups in my cohort and several and since PaCER began, a barrier to getting the support required to heal and the informed consent and all of those things is the hubris and the contempt and the paternalism and the misogyny and the racism that is baked into creating doctors and nurses. There's like, there wouldn't be contempt for the idea of informed consent if that wasn't there to begin with, right? So no matter what wonderful research we produce, we still need a mechanism for that to be taken to the clinicians and there to be an openness on the part of clinicians, a humility, humbleness on the part of clinicians to be open to learning from the patients, to be open to recognizing that the compassion and the empathy has to be there first in order for anything else they do to have any kind of positive effect. So what are the potential next steps to close that circle? And from a PaCER perspective, what we do to start trying to bridge the gap?
So much for your question. Any one of you would like to answer?
I think that journey has begun. I think, like, I can only speak from our perspective in the SCNs and the work that we do. You know, we have large core committees with nurses and doctors and policymakers, and we have PaCERs on every core committee who bring that work to those people. I mean, to me, it's progressive approximation. I have no influence on how people are trained. Some of these people may be, but by virtue of bringing evidence-based innovation to the forefront and showing the value proposition, we open doors to allow for more openness and responsiveness. So I think we started that journey, but I think it's a long journey. And so, you know, the way we'll do it is together. And the more PaCERs we have as, you know, pollinators, love that term. I think we will, I like the term progressive approximation because you make great strides in one community, but you haven't made a stride there. So I think, how do we walk this together, show the value? Because I think value drives more interest in how can I get involved. So I don't have a complete solution, except that's why I've been spending 15 years in the program, because to me, it's making a difference.
Yeah, I really appreciate your question. And I think there's lots of angles or directions or perspectives that need to evolve. And I agree. I mean, I think it is evolving, but there's always so much work to do. I do think we can, and some of this is starting to happen also on the training side. Also bring in these voices in the training program. There are, well, a lot of curricula. I don't know all the details of all the schools, but they are revisiting and they're starting to embed, I'm going to say, some of this thinking. I mean, it's not PaCER thinking, but bringing per se the patient voice into this, building in a learning and an appreciation that's important. There's been a lot of effort
towards thinking what patient-centered care means and trying to rethink that. You're probably familiar with many documents of the governments and things to try and bring that. So I think incrementally there is a shift, but it does take time, and I think we keep at it and having more and more, there's the power of the people, right? Having more and more voices to bring that, and people feeling through these kinds of programs the confidence to be able to bring that voice forward, I think will be the way forward incrementally.
I don't know. I was thinking about your question as a provider, right? As a provider, and I think as Dr. Marshall have said, there are efforts to bring patient perspectives into healthcare education. So bring it into medical schools, nursing schools, and allied healthcare professions. Something that came to my mind is that when you as an individual have a skin in the game, perspective changes. And as a clinician, I've been a patient myself. And maybe that's a place to start. Maybe it's knocking on the doors of health, the professional organizations, the bodies that regulate professions, to see if there is an interest. Because in all of those professions, at some point in our lives, all of us have been on that side. And something else that came to my mind is maybe one of the next steps that can be taken in the short or medium term for PaCER itself is to do a big map of the healthcare spectrum for places where the PaCER sermon, well, no, the PaCER concept needs to be brought to just a thought.
Thank you so much. Yeah, and in terms of time, we're running a bit late as I think usual, but doing our best. These are really interesting conversations, and we want to provide time for you guys to to have these discussions, and you guys ask questions and learn from each other. And so thank you so much to the panelists sitting here, Dr. Castillo, Marshall, Tracy, Westlake, and the people on the other side of the screen. Thank you, Joanne Gatton and Rohan De Sosa. Thank you so much for being here with us today.